Arterial blood gas analysis is one of the most commonly undertaken tests in the intensive care unit, so an understanding of the values that can be obtained is very important. Modern arterial blood gas analyzers can produce a lot of data. Some variables are directly measured, including pH, the partial pressure of carbon dioxide, the partial pressure of oxygen, and spectrophotometric analysis of hemoglobin. In addition, a number of calculated variables such as bicarbonate and base excess are derived. Modern analyzers can report electrolytes, lactate, glucose, hemoglobin, and even creatinine. These latter values will not be considered in this vodcast. The oxygen content of the blood is measured via a Clark electrode, also known as a polarographic electrode. This electrode consists of a silver chloride reference anode and a platinum cathode, which is charged to between 0.5 and 0.7 volts, bathed in a sodium chloride solution and coated with an oxygen-permeable membrane of polyethylene. As oxygen diffuses across the membrane, a current is generated between the electrodes at a magnitude proportional to the oxygen content of the sample. The normal value for a patient breathing room air at sea level is about 85 to 100 millimeters of mercury. pH is defined as the negative log of the concentration of free hydrogen ions or protons in the plasma. The concentration of protons in physiological conditions is extremely low, ranging from 35 to 44 nanomoles per litre. pH is measured by detecting a potential developed at a pH-sensitive glass electrode tip compared with a reference electrode. The voltage detected is proportional to the hydrogen ion concentration. The normal range for pH is 7.35 to 7.45. Carbon dioxide is measured using a Severinghaus electrode and is effectively a modified pH electrode as described previously. A Teflon membrane separates the sample from a buffer solution containing bicarbonate ions surrounding a pH electrode. Carbon dioxide, but not hydrogen ions, can permeate across the Teflon membrane to generate a measurable pH change, which correlates with the CO2 concentration of the sample. The normal range for carbon dioxide is 35 to 45 millimeters of mercury. Bicarbonate is a calculated value based on the measured values pH and pCO2 using the Henderson-Hasselbalch equation. The bicarbonate can also be standardized to a PaCO2 of 40, known as the standard bicarbonate. Under these circumstances, the effects of respiratory variation are removed, providing an estimation of the metabolic component of acid-base balance. The normal range for arterial blood is 24 to 30 millimoles per litre. Base excess is also considered to be a measure of the metabolic disturbance in isolation from any respiratory disturbance that may be present. It is, in effect, the amount of acid that needs to be added to a system once the PaCO2 has been normalised to return the system to a normal pH of 7.40. In effect, it is measuring the excess or deficit of the buffer base, which includes bicarbonate, hemoglobin, plasma proteins, and phosphate buffers. The normal range is between -3 and +3 millimoles per litre. A positive value, or a base excess, indicates that there is a process causing metabolic alkalosis. A negative value, or a base deficit, indicates the presence of a process causing acidosis. It therefore adds to the understanding of the metabolic process at hand, as it includes buffer systems other than bicarbonate. Because hemoglobin is also a buffer, its presence alters the recorded value, so most analyzers will now compensate for its presence. This is termed the standardized base excess and is thought to reflect the acid-base balance in the extracellular fluid. Co-oximetry refers to analysis of the content of blood using absorption of light at known wavelengths, or spectrophotometry. Red blood cells in the sample are shattered using ultrasound before a beam of light is passed through the thin film of the sample. Absorption of light is directly proportional to the concentration, known as the Beer-Lambert law. By using multiple wavelengths to analyse the sample, and the ratios of absorption of one wavelength to another, the co-oximeter can differentiate between types of haemoglobin, namely oxygenated haemoglobin, deoxygenated haemoglobin, carboxyhaemoglobin, and methemoglobin. Technically, arterial oxygen saturations, or SO2, is the proportion of oxygenated haemoglobin in relation to the amount of haemoglobin that is capable of transporting oxygen, i.e. it excludes abnormal types of haemoglobin. In contrast, the fraction of oxyhemoglobin is the ratio of oxyhemoglobin to all types of haemoglobin. The P50 is a partial pressure of oxygen at which 50% of the haemoglobin in the sample is saturated. It is thus a measure of the position of the oxygen-haemoglobin dissociation curve. The curve can be shifted to the right by increased temperature, increased partial pressure of carbon dioxide, and decreased pH. It is also influenced by the metabolic activity of the red blood cell, via the production of 2,3-DPG. Shifting the curve to the right results in enhanced offloading of oxygen at the tissue level. The normal positioning of the oxygen-haemoglobin dissociation curve is defined by a P450 of 26 mm of mercury. Oxygen content, or CtO2, is an estimation of the total amount of oxygen contained within the blood, both dissolved and bound to haemoglobin. Temperature has a direct effect on the solubility of carbon dioxide, which in turn influences the measured PaCO2 and the hydrogen concentration. In a deeply hypothermic patient, the pH becomes more alkaline. However, during analysis, most gas analyzers standardize to the temperature of 37 degrees. Whether to use the actual measured values or to correct these values to the patient's body temperature has been a source of considerable debate. The term alpha stat, which uses pH corrected for body temperature, and pH stat, where the absolute value is used, are often used to describe their application in clinical practice. Temperature also affects the measurement of oxygen. As a general rule, the measured oxygen increases as the blood is warmed to 37 degrees. To correct for body temperature, the value measured is reduced by 6% per degree of body temperature below 37, and vice versa. There can be some confusion regarding terminology. Acidemia and alkalemia refer to the presence of an abnormal pH of the blood. Acidosis refers to a pathological process that can generate increased protein concentrations in the blood, while alkalosis refers to the process that results in a decreased proton concentration. The distinction is important because an acidosis may not result in an acidemia, such as in mixed disorders where the pH may in fact be normal.